Okay. All right, guys, we're going to go ahead and get started. Thank you for coming to our 8 a.m. didactic on Wednesday at SAEM. My name is Dave Liu. I'm faculty at the University of Washington. Today we'll be doing a deep dive into the qualitative study that we did called Insights from EM Medical Bound Students who ultimately chose another specialty. Just for those who are even more interested, so we published this paper in AEM, I want to say 2 months ago. So if you want to do an even deeper dive into our qualitative data, feel free to go ahead and take a look at that paper. Just some disclosures. So this project arose out of our work together on the SAEM Workforce Committee, specifically the subcommittee on recruitment, and the study funds for this qualitative study were provided by the SAEM Board of Directors. So just the speakers today, again, my name is Dave Liu, I'm from the University of Washington. We have Arvind Akavan from the University of Washington. We have Brian Kane from Lehigh Valley. We have Joe House from U of M. Haley are one of our resident doctors at UW, and then Stephanie Balint from Quinnipiac University. So we're going to spend about the first 12, 15 minutes going over the data and results from our qualitative study, the cold feet study. And then we're going to spend about 10, 15 minutes at a panel discussion, kind of addressing issues that came from that study, as well as addressing it by providing socks for cold feet. And then we'll have a Q&A for the audience. So without further ado, I'll turn it over to Arvind.
All right, everybody, thanks for coming today this morning. My name's Arvind Akavan, as Dave mentioned. So our study, we had a qualitative study, an interview study of a convenient sample of medical students from across the country after the 2023 match. We recruited these students via a bunch of methods, so social media, things like Reddit. We went through Cord, CDEM, and snowball sampled as many as we could get. The interviews were one-on-one, semi-structured interviews. We had a kind of questions that we wanted to make sure to touch on and explore with the students, but we also let them guide the conversation towards things that they thought were important in their decision making, with regard to why they chose why they did not choose emergency medicine. These were all students after that chose another specialty in the 2023 match, but self-identified as having been very interested in emergency medicine during their time in medical school. We did thematic analysis, identifying a bunch of themes and sub-themes to determine what were the factors that really drove these students' decision-making, specifically away from emergency medicine. We ended up performing interviews and including data from 16 students across 12 institutions. Here's the demographic data. We don't have to go over it in depth, but what we did note was that we got the students that we interviewed were from a wide range of geographic regions in the country and also matched to many different specialties other than emergency medicine, including internal medicine, family medicine, anesthesia, path, radiology, in neurology as well. There were a couple institutions that had, since we did snowball sampling, that had a couple students from those institutions in our study. We, after performing our thematic analysis, we landed on a bunch of themes and sub-themes, and we had 5 major themes that we felt were really, based on our conversations with these students, were really important in their decision making. They're listed here, and we're going to go over them all individually, but they were the innate features of emergency medicine, the workforce report that came out while these students were in the midst of medical school, burnout, the perceived standing of emergency medicine within the healthcare landscape and in the hospital, and also early exposure to emergency medicine. We will also review some of the topics that came up that were not very important in their decisions, according to them. So our first major theme was innate features of emergency medicine. These were things that we felt were not really like the short-term modifiable factors, but were things that were inherent to the field of emergency medicine or the practice of emergency medicine that these students felt were fit or did not fit them. So the first sub-theme within this group was personality fit, and we're going to read these quotes out because we picked quotes quotations in our study that we felt were really representative of these themes. The first one of the things that initially drew me to emergency medicine was being able to have these very quick patient interactions. I was good at establishing relationships with patients early and quickly. Alternatively, one of our other students said, I didn't like the pace. I got to know my patients briefly when I was figuring out what was going on, but couldn't really build relationships with them. It sort of bothered me that it was very efficiency-based, like get them in or out as quickly as possible. So again, this is something where, depending on the student's personality or interests, these are not the most modifiable factor within emergency medicine. The schedule came up as an innate feature of emergency medicine also that really drew or pushed folks away. So one student, as someone who wants to have a family at some point, and as a woman in medicine, shift work and schedule flexibility in emergency medicine were appealing to me. Whereas another student stated, I think despite the concept of all that free time with shift work, there was a lot more time sunk into resting and recovery from the switching cycles than I'd realized. So again, just how those students fit with the schedule varied. This one was notable for us as something that came up in our discussions that we hadn't really thought about, but there was, these students had these perceived limits to what, how flexible an emergency medicine practice was in the future. This quote, student stated, other fields allow you to work in different settings, like being able to work in a clinic, in a hospital, or being able to, if you're a subspecialist in neurology, read EEGs in a non-patient facing role. So I was attracted to the innate flexibility built into other fields that wasn't so standard in emergency medicine. And one of the things that really struck us about this in our conversations and analysis of it was that when how the conversation was contextualized about the subspecialties within emergency medicine was always discussed in a way of like, oh, I'm like trying to leave emergency medicine clinical practice. That's why I'm interested in another subspecialty. Whereas with a lot of these other fields that these students chose, the way they contextualized that conversation was there's this cool thing within this field that I'm going towards. This one came up, unfortunately, as what seemed like a perceived innate feature of emergency medicine, which is violence in the emergency department. This quote really got me. A nurse got bit by a patient, and I remember asking and attending, what are we going to do about this? And I feel like they said all the right things, and it just wasn't enough. The answers were correct, but none of them made it seem like anything was going to change. So I think we all of us being emergency medicine folks in here have witnessed violence in the ED, and it seems like even our students that are witnessing this are viewing this as something that is not really a modifiable factor and is an inherent aspect of the job, which was really notable to us. We had, and now I'm going to pass it to Haley, Dr. Egan, for the workforce report.
So I'm going to go through all the rest of the themes that we identified. The first one, or the second one, was a major theme that came across was a really widespread awareness of the 2021 Emergency Medicine Workforce Report. One student said, the catalyst to me really second-guessing everything was the workforce report. It got me thinking, what else is there if this specialty is doomed to collapse? Another student said, what I took away from the workforce report was the overabundance of EM graduates as a result of things like for-profit corporations capitalizing on the ability to create EM residencies and pump out as many residents as they could for cheap labor. One thing that was kind of interesting about asking the students this question was that when we asked directly, did the workforce report affect your decision? They often said no, but then they went on kind of unprompted to talk in great detail about what they thought about the report, faculty and residents they had talked to about the report, things they had read online about it, and they could name several students who were considering EM and switched to a different specialty because of the report. So it really seems that even though some students didn't personally identify the report as a huge factor in their decision, it really kind of speaks to the widespread awareness. It was definitely something that was really commonly discussed. Students also really sought advice from those around them about what the workforce report really meant for the future of emergency medicine, and several of them noted being quite dissatisfied with the responses that they received. One student said it felt like they were kind of beating around the bush and just saying the data isn't great, this was a flawed report, finding something else to put the blame on to declare it as false. Many students also search, kind of like turn to social media. A lot of them recognize, that anonymous platforms are not the most reliable place to get your information, but a lot of them noted turning to that because they didn't feel like their questions were being adequately answered. One student said, I saw a lot on Med Twitter and Reddit. People will go there to complain about their job search. I tried to take it with a grain of salt, but a lot of people were saying, if I could go back now, I would have chosen a different specialty. Another theme that is prevalent in not only emergency medicine is burnout. Several students really pointed out the concept that we kind of think of as moral injury. As the student put it really well, as an EM doc, you kind of have to deal with every way in which society fails people, especially the most marginalized and vulnerable people. And you can't do anything about it. You can bandage them, patch them up, send them back out, and they'll show up a few days later. I think that sometimes the failings of the system were so much more evident in EM than they are in other specialties. Another interesting thing that students noticed was many of the providers they were interacting with were noting that they were trying to find an exit strategy from emergency medicine, whether that was like decreasing their clinical responsibilities or leaving clinical practice altogether. The kind of implied was because of burnout. One student said, I could tell people were tired, and a lot of them were talking about their exit strategy, and I didn't want that to be me. A general sense of kind of disrespect towards EM providers in the healthcare setting was noted by quite a few students as they rotated both in the emergency department and rotated on other specialties who interact with the emergency department. One quote that I think is very representative but not on this slide is that one student said, one thing that did intimidate me about EM was having to go up against the questioning of your clinical calls and pushback from everyone in the hospital. I think personally, as a resident who's usually the one making these calls, I think that that was a very good observation and something that I personally feel like my clinical judgment is kind of questioned on a daily basis by consultants. And it's interesting to know that students are picking up on this as well, both kind of in and out of the emergency department. Residents and faculty in other specialties also freely offered their opinions on pursuing a career in emergency medicine to some of these students. One student said, when I would say I was interested in EM, people would be surprised and they would say, why would you want to do that? And then a couple of students also noted that the treatment of emergency workers during COVID was fairly poor at their hospitals. One student said EM was taking the brunt of patient care during COVID, and I saw the administration not being very supportive of the people in EM who are on the front lines. And then the last theme that we kind of reached was the importance of kind of early exposure to EM. As we all know, a decision to pursue a specialty is really heavily influenced by the people you meet, the experience you have on the rotation. And that is both kind of in the clinical and preclinical setting. One student said, in medical school, what you choose is so much a product of your rotation experience, how nice or engaging your attending was. Several students also noted that their initial interest in EM was started because they worked with a very cool emergency medicine physician in their preclinical years, usually during those kind of small group, like intro to clinical medicine type settings. And several noted that they had really good kind of prevalence of EM providers in those roles. Interestingly, many students actually did not have a required emergency medicine rotation, and a couple of them noted that they felt like their rotation was too late for them to change their decision. I think on a personal note, I was a scribe in the emergency department in undergrad, so I came into medical school on day one knowing I was going to be emergency medicine physician. My school did not have a required EM rotation, and several of my colleagues went through all of medical school without really any exposure to emergency medicine and what that specialty was like. As someone who really strongly disliked every other specialty I rotated in, I often think, like, where would I have ended up had I not come into medical school with that, already preconceived idea that this was the path I was going to take. One student noted as well, I think one thing my school could have done better was to have a mandatory EM elective, especially because we have an incredible ED. I think they note that kind of giving students the early and kind of required opportunity to explore emergency medicine might give them more time to plan for things like fourth year schedules, away rotations, and things like that allow them to more easily pursue emergency medicine. I'm going to hand it back to Arvin now.
And, we explored a bunch of other factors, both that we prompted the students, but also ones that they brought up as, things that may have not that were less impactful to them. Some of them, we're listing them here, some of them were pretty surprising to us. I think salary expectations was pretty universally stated was not a factor for them. I think we did look at the specialties these students did go into, and all of them were none of them were the highest paying specialties. So it may have been a little bit of obviously selection bias there. COVID-19 didn't come into their decision making at all as a major factor, which we were surprised. And then the big one that we kind of touched on already was the fellowship options, where it didn't seem like students were choosing emergency medicine in order to pursue any specific fellowships, but it also didn't feel like it was a major factor in pushing them away, other than that perceived flexibility of future practice in some way. We also asked about educational debt, family expectations, and diversity of the workforce, which did not seem to be very important factors for the students we interviewed. So in conclusion, we identified these 5 major themes that were described as being very impactful factors for these students who were considering emergency medicine strongly but decided against it and to go into another specialty. And we're happy to review them all together now and talk about them.
So we're going to just go ahead and do our sort of questions for our panelists here, but I want to make sure this is open. So if people have anything to chime in, questions, feel free to just raise your hand and answer. So our first question for the panel is, so what are the main takeaways from this study given the 2024 match results?
So again, I'm Joe House. So, I mean, glad to see that the numbers rebounded, but I think if you look at a lot of these topics, I mean, they really haven't been addressed to this point. I know with our faculty, we're still dealing with burnout. We're still dealing with the violence in the ED. So again, numbers look better, but I'm not sure exactly what that means in reality. I think once we start addressing some of these concerns from faculty, I mean, obviously the students pointed it out, which, I think if the students are picking this up, then it's probably a bigger problem than what we may be noting as faculty.
So, Dave, thanks for giving me a chance to answer this question. I'm going to answer it kind of through the 2 hats that I wear. So I've been an APD for 16 years, and I'm actually chief of staff for a medical staff that covers 14 hospitals. So I bring that up primarily to say I clearly am going to have biases based on that life experience. So in thinking about this, there's a couple of things I might add. The group that we interviewed in this particular study, I think, is the group that in the last couple of years, when you look at the match data, is to a degree relatively underrepresented. The match numbers that increased this year did not, at least in the data I've seen, come from MDs from medical schools within the continental US. And I'm not arguing whether that's a good thing or a bad thing. I'm just saying the group we interviewed represented that group. So that suggests to me that while the N is small, there probably is some truth in the universe to the themes that are up on the slides that we've talked about. And I don't want to go into too many of the specific and explicit themes, but to jump on what Joe said, I think there's a lot of opportunity for people in this room in general and SAEM in particular to start to have a bit of an organized approach. The last thing that you had said was at your shop, just like at my shop, we're struggling with a lot of these things. I wonder, and this is just based on the experience we have at my place in Allentown and feedback we've had from our students, we tend to be pretty open as humans, and the way we work in the ED, at least at our place, is a single attending with a single resident and a single student. So you really get to know one another over the course of that 9-hour shift. And are we maybe oversharing? And are the residents oversharing? Because I suspect in the surgical lounge, the surgeons are oversharing. It's just the students aren't there because they're running around on the floor trying to get their work done between cases. So there may be an opportunity for us to be, on a very simple level, thoughtful about our dirty laundry and what place we hang it up for everybody to see.
Yeah, that's the one takeaway that I did personally was I typically don't complain very much on shift, but I'm super sensitive to that now. I do not mention anything, roll my eyes, just because I now know that it's picked up on by a lot of different people. All right, what are the strengths of our specialty that attract students? How do we emphasize these strengths to potential applicants?
Start.
So I'm Stephanie. I'm an incoming M4. So I was very lucky to know that I was interested in EM, but as we were discussing before, this past year, just incidentally, I have a lot of new students coming up expressing their interest in EM. And currently it seems like a lot of people's exposure in their M3 or M4 year, depending, especially coming from the internal medicine and surgery worlds, and now they're experiencing this emergency medicine several years post-COVID, so things are a little bit more like they used to be. People really seem to be enjoying their experiences, especially in contrast. So I think the teamwork there seems to be really different than other settings, and a lot of people express that they love feeling valued and feeling part of the team, even as a medical student. So I think that's something that maybe has drawn us here, and if we can like highlight that more, especially like the interdisciplinary teamwork, people seem to comment that they love working with the nursing staff and things like that. And then also the recent increase in medical student membership for SAEM, I feel like that's a really good sign that here we have a lot of opportunities for mentorship, and med students love mentorship. So the way we can kind of expand upon just increasing more opportunities for med students to get mentors here. So those are some of the things. Thank you.
Yeah, and I think some of those innate features of emergency medicine that we talked about at the beginning, that are, you know, the pace, the variety, the procedures. You're seeing these like first presentations of very classic disease illness are some of the best parts of our specialty. I think with the second question of how do we emphasize these strengths, I think Dave and Brian mentioned we are kind of a fishbowl. Like we don't have this like doctor's lounge where we really go to in our specialty that we can leave the negative conversation behind. But I know one thing since we did this paper I've been trying to do on shift is I take the medical student afterwards and I instead of saying oh man all those things that we complained about today, I talk about all the cool things that we saw throughout a shift. And when I've started doing this, it's surprising how much there is, even on the shifts that maybe some of us, because we've been doing this for a while, are like, oh, this is kind of a mundane shift where they'll this like crap happen that is always frustrating to me. But to these medical students who are interested, the chest tube we did, or the intubation we did, or the septic patient we treated were like really important. Were really important events for them during that shift, and highlighting them and talking about them has seemed to, I feel like for me, get good feedback.
Yeah, it's kind of like, you know what, when residents always say we never get teaching, and then you like have moments where you actually sit down and say, this is teaching, we are gonna teach. It's the same thing with students, right? It's like, oh, I suppose, this is just a regular Monday. Like, no, from a student standpoint, you saw a 90-year-old, then you saw a 9-month-old, then you saw the OB patient. So pointing it out explicitly might be actually helpful.
So I have one comment.
Yeah.
Just Mary Ann Davies from LSU Shreveport. So I think that one of the things that we can also do is turn one of your negatives into a positive, and that was your comment that they had about dealing with societal ills and these patients that are that don't get to the clinic. The reason that we see them and it's not seen in other clinics is other specialties because they don't get to the clinic and they don't get there. So I think that if you look at the students who really want to help society, tell them EM is the place to go because you're the one who can make that extra phone call, get them to the clinic, get them where they need to be. Whereas the other specialties can't do that because they never see that patient.
It's like you're reading my notes for question 3, but just to extend on that a little bit, there are now regulations, right? So that's kind of my chief of staff hat, where when external regulatory bodies like the Joint Commission come to your institution or your network, we are now required to provide data on how, as a network, we're addressing healthcare disparities. Well, we're the front door for that, right? And isn't that an awesome opportunity? If you look outside the EM literature at some of the sociology literature, an example, Jean Twang, and I believe she's at UCSD, she spoke at court a couple of years ago, the people we're trying to recruit, that is part of their core and their values, is being part of something larger. And how do you help with that? I know several of the specialty societies got together and put together a video a few years ago about the history of EM. And there's this great scene by Dr. Goldfrank talking about we're having a VIP that's coming in, and the VIP just is the next patient. and the next patient unfortunately happened to be without shelter. That's what we do every day. And for our learners, that may be their first pelvic exam or NG tube or IV, and they love it. So just naming that we provide 40 to 60% of the opportunities to do procedures for all 4 years of med school and 4 weeks of EM, we have such an amazing opportunity to signpost a lot of the stuff that we take for granted.
And I think we even have residents within our program that are really like, some of them are sitting here that are taking on, like adding to their specialty, their practice of emergency medicine, these like fixes to some of these societal problems, whether it be opioid use disorder or contraception, stuff like that, like within the emergency department. That's part of the field, as opposed to, you know, again, contextualizing that as something that you do as part of being an emergency medicine physician, because that's where it's done, as opposed to that's something you do to try to get away from the practice of emergency medicine.
Yeah. So that was the perfect segue to our next question. So what are the weaknesses of our specialty that dissuade students? Is there a way to reframe these weaknesses without misrepresenting our specialty?
All right, so I'm going to kind of get close to what Joe wanted to talk about, but you heard me talk already about how we could reframe things like moral injury. It was already said where we have these opportunities to really signpost that we're the diagnosticians left in the House of Medicine. When I was a kid growing up in the 70s, that's what made a doctor really cool, right? Was being able to make the diagnosis, and I'm sure every day, every one of us has that sense of that patient that's sent in. So I'm a big fan of positive psychology, that if you can kind of look at the areas where you're having difficulty, how do we think about that in some specific ways? So I'm going to leave violence in particular for one of our future questions. But when we think about scheduling and we think about burnout, I think there's some opportunities there. So we're actually studying burnout internally at our place. And a lot of it has to do with what tasks you're doing and when you're doing it. So one of the things I try to do with students often is to say, during the stages of my life, there were different things that were important to me at different time, and I could work with a schedule committee, because we're blessed to have an internal schedule committee, to make what I'm doing in my life work with a group, because you put enough people together, there's always somebody willing to work that weird shift. So I was a nocturnist for 12 years. I now work every Christmas. My kids are stinky teenagers. And you know how cool it is when you leave on Christmas Day and you have this sense that you were on the wall, everybody else, and you were there and you helped, and everybody else was closed. Though that's a way to take what might be a pebble in your shoe and spin it to the positive. And I know you wanted to talk a little bit about when people are working. The Gettle.
Oh, so that's the next question.
Oh, yeah. So there was this paper that came out last year that showed pretty concerning, I think, data, in my opinion. So they found that male emergency physicians exhibited attrition at a median age of 56 years. Female EPs showed attrition at around a median age of 44 years. 1 in 13 males and 1 in 10 females exited clinical practice within 5 years of residency graduation. So the question for the panel is, are students right to be concerned about career longevity in EM?
I mean, I think looking at this data, I'd say, yes, there's a right to be concerned. I mean, one thing I admittedly don't know is what the data looks like in other specialties. So I think if you look at some of the other specialties, there's going to be, maybe not exactly the same, but similar numbers. And I think, yes, we want to paint the nice picture for the medical students. I mean, my view on it, we also need to be honest with them. They need to know, about the ins and outs, because what you don't want, and I think, with these students that, are soaping into EM with the open spots last year, that came up in a couple of discussions I was in, how many of those are going to leave because they're coming into a specialty that maybe they don't know as much about, and they're kind of, somewhat of a shock to their system. I think, talking about some of the flexibility for EM, I think emphasizing that, like you talked about, looking at the schedule, are there things we can do for that? One thing that we're doing at our shop that we just started is actually looking at, giving providers a month off. And what that would look like is, if you work, 12 shifts a month, you're just going to work extra for maybe those 12 months before, do one extra shift, and you're banking it and actually have an entire month off. So again, giving people a reprieve, or kind of banking that time and giving a half month off, things like that. So I'm planning my spring break next week or next month, or sorry, for next year, and it's going to be a long 2-week trip, and I'm banking my hours now so that way I can get that time off, and I don't have to worry about I'm going to work all 12, 15 of my shifts right before I go, and then 14 shifts in 14 days, and then go on vacation. It's that spreading that time out. So I think looking at that flexibility, but again, I also think we need to be honest with our students what that looks like. I mean, yes, it is great being the front line and being that provider, but also talking to people who you talked about with all the other parts of it. You have these patients show up and I'm sorry you couldn't get in to see your primary care doctor today. I'm sorry it's 6 months to see the GI specialist, and noting that it is frustrating when there's not much you can do for those patients. So again, I think being honest to providers, so when they're getting in, they're kind of knowing what they're getting into, I think is part of it too.
So I'm glad you brought up about other specialties. I can say at least at our place, I'm sorry, go ahead. 80% of our primary care physicians work a 0.8 FTE. So this is, I suspect, not unique to EM. And to your point, if we're advising students, I think we can certainly acknowledge. I know I'm at a place in my career where I'm starting to think about how much of my FTE do I want to be clinical, how much do I want to be something else. Our network CEO is actually an emergency physician, and when we've had some dinners together, he specifically said he got into the MBA and organizational track, again, as I was alluding to earlier, where he was with his family, he needed stability in his schedule, and he said, if I have non-clinical time, then I can use those days to be at my kid's soccer game or whatever. That we're really blessed with flexibility to ramp our FTEs up and down and move left and right. We're not building panels of patients. So again, there's a lot of concern there about burnout, but I don't think it's unique to us. A lot of parts of our network, the most common thing that happens after an FMLA, for instance, after a child is born, is the physician just doesn't return to their prior FTE. They just stay at their FMLA lowered level, to the point where the workforce report may need to be recalculated because the expectation of hours worked generationally is perhaps very different.
A gray pearl, as one of my dad used to say, where you're not quite sure if it's black pearl or an actual pearl, but kind of a gray pearl. I'll talk to students about the fact that emergency physicians too, I feel like some of this is possibly not just due to people being like, I want to get out of emergency medicine because I hate emergency medicine, but I feel like a lot of emergency medicine physicians are kind of agnostic in that, like, I want to get my time in, work my stuff so I can go live my life after this. I'm going to become financially secure so that I can go and jump off the cliffs and ride mountain bikes and all that kind of stuff. And also, like, our attention spans are generally shorter, I think, than average physicians. And so people reinvent themselves around these times, right? Like, you see emergency physicians becoming entrepreneurs and starting a business. It's not that they're leaving life and retiring completely. It's just that they found something else that they've worked to get to the point where they leave. So I think some of that is baked into some of these numbers. That's what I tell students, because I feel like a lot of folks that I know that have left medicine at these ages actually have another plan. It's not just like, I'm done, I can't stand this. Maybe one I saw that couldn't stand it and left, but otherwise a lot of them have a plan to drive it. I don't think that explains obviously the difference between male and female emergency physicians. I think there's a lot there, but anyway, I don't know if it's a lie or not, but that's what I tell students. I'm not like that though. I'm gonna work with 1 kid probably.
So in my other sort of life, I do a lot of research on burnout, and I always get asked by residents, students, like, what can I do? What's the one takeaway from burnout that I should take away? And I always say, like, if you want a longer career, especially in EM, the trick that I've learned and passed on is find that 20%. So if you have that 20% of whatever you do that you find you're passionate about, that you love, that will make you tolerate the other 80% of the crap that maybe you're not so excited about. So for me, it's the writing, it's the research, it's the stuff about burnout that really drives me. That will make me tolerate the other 80% of stuff that I'm not so excited about, overnights and things like that. So whatever it is, EMS, ultrasound, admin, education, whatever it is, find that 20%, and that may sustain you over the long term of your career. So Someone kind of presaged this. So it's been 4 years since the publication of the workforce report. What is the current perception of this report among students and residents?
So I can speak kind of from the resident perspective, and this was actually a really interesting question to think about because this was such a big thing when I was applying. My application year is when the report came out. And similar to many of the students in the study, I can name 10 people off the top of my head who switched from EM into another specialty because of the report. And so it was such a big thing for kind of my year and maybe a year or two after. But it's kind of interesting to think about from a resident perspective now. It's really like a non-entity to us because most people who are in the specialty kind of around my time have kind of chosen to pursue this career really despite the report, and the report didn't really sway us. And so now it's just not something that we commonly think about or are really influenced by at all. And I think, too, I polled some of my colleagues and asked, are medical students asking you about it on shift these days? And most of them said, medical students will ask, well, what do you think is the future of emergency medicine? How was the job search this last year? Those kind of questions, but rarely, if ever, is that workforce report really directly addressed, at least with the residents, by the medical students. And I think that those questions that medical students are asking are questions that everybody's asking, like regardless of the specialty. And so at least now from the resident perspective, it seems like maybe we've kind of moved away from like directly addressing and being directly concerned about that report, which I think may in part be due to kind of the match numbers and the couple years after, and that may have kind of fixed that issue in some people's minds.
And similarly, it's the general consensus amongst the medical students that I talk to is very positive right now. It's almost as if it seems like people were waiting for a positive sign. They were really interested in EM and just waiting for some sort of positive numbers to kind of get them back in that mindset. And also, we were talking before, medical students are so brilliant. So many of my friends are so brilliant and such empiricists about everything from like medication dosage to procedures. But the one thing is they do love their Reddit and Student Doctor Network for workforce information. So I think that even just the positive numbers coming out this year, that just really helped swing the vibe in a more positive direction. And so, yeah, generally, again, I am a little biased because people may be just excited to tell me good news, but generally I'm hearing very positive things.
Okay. So one of the novel things in our study that we were not expecting to find was that some students cited workplace violence was a deterrent to choosing EM. What can we do as a specialty about this problem?
So it turns out workplace violence is a thing when you look at it through the lens of regulation. I think we all know it's a thing when we go to shift. And for the students to have noticed that, I think it gets back to they're incredibly smart and they see and hear everything that we're saying. So turns out our institution started a workplace violence committee in 2019, and it was entirely populated by psychiatry. I only learned that because of my position in chief of staff. And we unfortunately had one of our nurses who was significantly injured in February, admitted closed head injury with bleeding, major joint dislocation in the ED. And I would never want anybody to have to go through that, but what is it leveraged? It's leveraged an opportunity for emergency medicine to now be at the table in our network in those meetings. So what I guess I'm trying to share is, if this is a topic of importance to each of you, there are regulations, and I'm happy to talk offline, but the Joint Commission has definitions of what constitutes workplace violence, which I think would shock most of us, because I'll often say to patients, if we've had some heated discussion, when everything calms down, well, you didn't spit at me, so I gotta be honest, you're not memorable, because I think that's an attitude a lot of us have taken. But there was probably workplace violence embedded in that if it got that heated. So find your workplace violence committee at your hospital. Joint Commission requires it. OSHA requires it. There's a lot of regulations around this. And then I think as a specialty and SAM, this may be an opportunity for us as a group, really need to start to maybe come up with some definitions. And the reason I bring that up is at the last meeting, at our side at least, there was a whole conversation brought up by psychiatry along the lines of what is the threshold to get law enforcement involved? Mm-hmm. And I know that is a very sensitive issue, especially within emergency medicine. But if it's being brought up by our psychiatrists, I would suspect it's being brought up by other people at other places. So one of my mentors told me if you're not at the table, you're on it. So get at the table. I know your hospital has one of these committees because they're required. Have your voice be heard and be part of what you feel is your site-specific solution.
And we were actually talking about this the other day, and I feel like there was a study that came out a couple of years ago out of Northwestern where they interviewed students, residents, faculty, and EM about workplace violence. And I think one of the things they found was that our threshold is actually quite high and different from other specialties. I think what we consider normal behavior would not be considered normal in other specialties. So I think, like what we were saying earlier about calling out education, calling out variety, we have to call out verbal abuse, call out violence for what it is so it's not normalized.
Yeah, I think that word normalization, how our threshold changes. In this conversation, Dave, Haley, and I were having, I had a case where there was an assault towards me in the ED like 3 months ago, and to me it was like, oh, whatever, it's another day at work, let's discharge this patient. One of our security officers actually called the police on this patient without me knowing, and they came, they took my report. I was like, well, I don't know if I even want to talk to you about this. This is a normal day for me. And it really struck me as I left and reflected on that event after shift that I felt bad for this patient for what happened to them, even though the patient was not the victim of the crime. And I think there's a lot of loaded discussion about what's right and what's not right in this situation, and it's specific to each patient, I think, and specific to each situation. But at least having that discussion about where our threshold is really important. One, because medical students see it, but also I think that when we talk about attrition and the long-term sustainability of this job, both for us and for our staff, I think it's hard to keep people who are compassionate and engaged and excited and want to do a really good job if they're being abused and assaulted all the time. So.
As we were kind of talking about this the other day, I think one of the things that came up was, again, like you were saying, like how normalized it is and how I'll be on shift and I'll say that patient swung at me, but they didn't get me. And that's just kind of a regular day. As part of kind of discussions, both like with medical students, with faculty, with my colleagues, and like I think like my family too. You know, sometimes I tell them things that happen at work and it's really shocking to them, and it's so normal to us. But I think kind of recalibrating what normal is for us, especially for medical students, I think is really important, and to not talk about it so cavalier and casually, and make sure that when those things are happening, they may have missed you, but it's not right that they swung at you in the first place, and that's not something that should be normal in kind of your everyday conversation.
So our last question for the panel. So the 2024 match indicated that more DOs and IMGs compared to MDs are applying to medicine, EM. What does this mean for EM? Does it matter?
And I'm going to say, I think someone brought up the gray pearl. I'm going to say maybe it's in that gray area. I mean, I think it depends on the applicants. I mean, there are great IMG applicants, there are great DO applicants. I think we need to look at kind of maybe why the MD students aren't applying. Do a shameless plug for a survey that we recently sent out to clerkship directors. Looking at early exposure. I mean, is that where we're missing? Is that our allopathic students just aren't getting exposed to it until that third and fourth year where they've already made decisions? Are we seeing the increase in DOs and IMGs? Because again, looking at the open spots, they're thinking it's maybe an easier match, and that's why we're applying for it. So I think we just need to kind of delve into it a little bit deeper. But I think all those things. Again, if there's strong applicants and strong students, then I think it's fine for EM. If anything, they bring in a different mindset, which is a good thing, having that diversity in experience, diversity in individuals. But I think it's just something we need to monitor over time.
So you're saying there's a survey that was just sent out from the workforce report that we should all do?
Exactly.
Awesome. I don't know if you guys heard there's a survey that was just sent out. I actually look at this question maybe a little bit differently through my role with Chief of Staff. Our hospital that's furthest from our population base, which is Allentown of Billy Joel fame, for those of you old enough to know the song, yeah, they are still tearing all the factories down. The average age of the med staff there is 66. For better or for worse, at least in the economy that we work at in eastern Pennsylvania, we have made the strategic decision we are no longer considering building hospitals. We're building what are called joint venture community hospitals, where the goal is to have, based on state regulations, no more than I think it's 10 or 15 inpatient beds attached to an emergency department with a medical office building where you would house all your radiology and lab backup. So what does that mean? Every time we open one of those, you need the FTEs to stock that 24/7 emergency department because it has all the regulations that the level 1 trauma center has when the state agencies come in. I think we're looking at a very different workforce, or at least if I was to say what I need to recruit to care for communities, it's who are you going to recruit that's going to be willing to work an hour from that major population center in a single physician covered standalone ED? And what training opportunities do we have for that? And getting back to this question, within that pool, who's going to end up with the best skill set to do that? Because that's where the jobs are. And those are the people in our communities that most need emergency medicine. Because when those 66-year-olds retire, that's an entire small city with no med staff and nobody to care for them.
No, I want to highlight that. Nobody's done the study, but when I looked at the SOAP this year, it was very notable to me that it was anything that was smaller or further from a population base in terms of the residency programs. And I think that the MD students are talking about it with their feet, going to the urban population centers. It doesn't have very much to do with really great programs that are in small sites. Those are places that are still out there that were still in the SOAP. And frankly, if you look at the workforce study, what they did is they literally gave up the emergency departments in small rural areas. They said, we're just never going to staff those, and so we're going to pretend they're not out there, and that's why we have too many physicians in the workforce. I mean, we literally gave up some of the EDs and some of the places we work because we can't get people out there. So if we have to decide as a specialty, are we really giving up that because people just aren't willing to go work there? IMGs and then historically DOs have schools that staff those smaller places are the ones who are willing to go out there. And so I think it's something our specialty needs to think about.
So I'm a third-year DO student, and I think a big thing, so at my school, EM is a required third-year rotation. Also, almost all of our, we don't have specialty-specific staff, so we just have a primary care department, and they just kind of hire whoever to fill adjunct roles. And the majority, if not all of them, are EM physicians from the hospital right down the road. So all of us from year 1 through are thoroughly introduced to EM, and even a lot of our OMM faculty are also EM physicians. And so we have a lot of exposure, I think, by the time third year rolls around. And like in my class especially, we have, I probably named 30 right off the top of my head who are EM is like their number 1, who go to conferences and all that sort of stuff. So I think that exposure early on has been like really big, especially in my school.
And I think that that's important exposure early on, but there are barriers to that as well. And some of that is, and a lot of that is at the MD schools, there's a barrier to that in that our school is talking about making it a required third-year rotation, but that quadruples the number of students that come and they don't want to give us any more faculty. So how do you work that in and still be able to give rotations to the fourth-year students? So it requires, a lot of that is going to require a lot of advocation in the dean's office to be able to have that happen for a lot of these schools, which the DO schools don't have that barrier as much as the MD schools do.
So last comment real quick.
Yeah, I just wanted to ask, because you guys mentioned at the very end, it's like not having that rotation was a big did you guys take a look into the medical schools, like, whether or not they become a third-year medical school and completely remove the EM rotation, or it's because they're primary care and they're not including emergency medicine as part of that, or is it like because of COVID and everything now being mostly virtual that they're not having their EM meetings, they're not meeting these attendings in person anymore as factors that affect them in the preclinical setting?
Yeah. I don't think we dove into that detail, although the survey that we are doing will dive a lot deeper into EMIGS exposure. So yeah, we did not have the chance to go through this in our qualitative study, but good question. And then Doug, did you have a quick?
Well, now I wanted to follow up a little bit on what Mary Jo said, and I think that it is so important. So when I talk to students about the workforce report, that's one of the things that I point out, right? It's like it's actually jobs in these big urban centers that are hard to find. And all of us in this room get the postcards from the place in the middle of nowhere. It's like, we'll pay you $500,000 to come work for us, right? And students are interested in going to these places, but it's really, really, really hard due to the regulations that ABEM has, right, and our RRC has, to get students trained so that they're comfortable working in these places, right? All of our training occurs in big urban trauma centers where you have all the resources, and then you look at a job where you're like, oh, you don't have any of that stuff. Maybe I'll just stick in the big urban trauma center. And so I think we really, really, really need to re-examine our training criteria and open up doors so that we can train people who are comfortable working in those rural areas. Because that's where the jobs are, that's where we need the people, and we need to train people. And I interview students every year who are interested in working in those areas. It's not that there's no interest, it's that after graduation, it's a daunting task to go work in a place like that.
Well, we're out of time, but thank you for coming. Again, this was just like the surface. I highly encourage everybody to look at our paper. The quotes were just really eye-opening, so feel free to take a look. Thank you.